Well, thank you very much, and thanks for inviting me to join you at this in this conference. See a lot of old friends, Rick over there, who got us all started on this. Canada is, let's see if this, I guess, do I need the other one? There's a Mac, yeah. There we go. So I have nothing to disclose. Canada is undergoing a fairly significant revolution in residency education, and I'll be talking about it at greater length tomorrow, but it emanates from our college, which is pushing forward a movement to transform all specialties to competency-based education, and when I discuss the elements tomorrow, you'll see that it's a pretty radical change. We at our university, which is Queen's University in Ontario, are trying to transform all of our programs all at once. And again, I'll talk about that tomorrow. But when I analyze the elements, the major elements of competency-based education as we're defining it, these are the elements, but these are the enablers to make it happen. And one of those enablers is to significantly ramp up simulation through all of our programs. And this is not just in surgical programs, but across all disciplines. So I'll spend the next 8 minutes talking about the theoretical framework for simulation, some evidence for its value proposition, and conclude with some challenges. The first would be that to really talk about the theoretical framework for competency-based education, which departs from a traditional educational model and starts with the health needs of the health system and orients that towards the competencies that are required for a suite of outcomes. Only then does it define both the curricular and the assessment elements. It draws heavily on Kolb's learning cycle, going from a concrete experience, relying heavily on the ability for reflective observation, for abstracting conceptualization, and for active experimentation. It relies heavily, as we heard before in some of our talks, on the issue of mastery learning. This systematic review and meta-analysis of mastery learning concludes for us that there's evidence to show that mastery learning in a simulated environment is superior to non-mastery learning. This is a picture of Anders Ericsson, who many of us know as the father of deliberate practice. And as summarized by Bill McGagey and colleagues, these are the components that make effective deliberate practice. Well-defined learning objectives, focused repetitive practice, rigorous reliable measurements, informative feedback, monitoring error correction, and more deliberate practice. Well, if you really look at that, that cannot be done alone in an operating room environment and really requires an adjunctive environment to truly have effective deliberate practice. This study from Australia was a systematic review of skills transfer after surgical-based simulation and led to the conclusion that there's strong evidence that simulation activities in the lab can transfer into the operating room. This study that emanates from Denmark was a meta-analysis of 12 studies that cumulatively looked at 240 participants and showed that there is reduced OR time between 17 and 51% for simulation-based training compared to non-simulation environments. And this is probably the single best study that I know of that looked at novice residents, randomized them to a conventional group and a specific simulation curriculum. And then the outcome measure, sorry, I'm just getting your head, Denise, was a laparoscopic right hemicolectomy that was videotaped. When those were critically analyzed, there was improved performance in virtually all dimensions of performance in the simulated training group. Whoops, I just skipped a paper. This next paper from Michigan talks about the fact that simulation, and this is in mock codes, was significantly correlated with improved survival rates in pediatric patients undergoing cardiac arrest. And a study from Northwestern showed that if you use simulation training, and this is in the context of an ICU, one can yield substantial cost savings due to reduced catheter-related bloodstream infections. Some of our research when I was in Toronto, literally over a decade, was working on the objective structured assessment of technical skills. And again, that platform would not have been possible without the use in a simulation environment. So in summary, I think we can safely say that simulation in the context of educational reform in competency-based education, it works. Skills can transfer to the operating room. Indeed, I think we have accruing evidence that it can save lives. It can also save money, and it can serve as a platform for assessment. I had the great occasion a few years ago to rummage around the UK and then present my findings at the Association of Surgeons of Great Britain and Ireland. And my task was to look comprehensively across the UK and understand what they were doing well and what they weren't doing well in simulation. This was a slide I used at the time. It was a kind of a graphical description of what I found, and I don't think it's dissimilar in the United States or Canada. There is a large presence of low-tech models and box trainers, not a whole lot, but reasonably significant of use of sophisticated models, not very much cadaver training, I'd say even less team training, and virtual reality machines had a very low penetration. And that becomes germane when one looks at this slide that talks about fidelity and interest. And the reality is, in a population of medical students or junior residents, a simulation lab provides a great deal of stimulation and sustained activity, whereas as the fidelity decreases, so too does the interest, particularly for simulation for senior trainees. So we really need to focus our efforts at the more sophisticated simulation modalities. And what I also found, and I've seen this, and I visited approximately 100 simulation laboratories around the world, and unfortunately, a lot of them are in cobwebs and dust. And that's always after initial enthusiasm, flurry, and penetration. And the reason for that, and I think a message for us all, is, and this draws from a slide on CBME, is that simulation will work, and will only work, if it's deeply embedded in the curriculum, which to me gets to the heart of what we're doing now across Canada, and in particular in our medical school, is we're having a very hard look at our curriculum, making sure simulation is embedded at each and every stage for each and every learner. We're coupling that with explicit EPAs, which I'll talk about tomorrow, and trustable professional activities, and their concordant milestones. And we're comprehensively reforming assessment that will include a simulation platform for our learners. So I'll stop there. Again, thank you for asking me to come and talk. I'll talk a little bit more about this tomorrow during the Carl Stortz lecture. So thank you very much.